Episode of Prescription for Primary Care. I'm Tanya Dodaro, your host for today's episode. We are honored to have two representatives from the Nurse Practitioner Association of Manitoba with us today, Ashley Carruthers, CEO, and Cindy Fehr, who serves as both a policy consultant and member of the board of directors. Welcome to today's discussion.
Thank you.
Thank you for having us.
Can we start off with just getting an overview about what a nurse practitioner is, what the Nurse Practitioner Association of Manitoba does, their mission, and how you both became involved?
The key that needs to be started in terms of our discussion right now is that they are autonomous primary care or prescribing practitioners that can diagnose, order diagnostics, treat, prescribe. So all of the essentials that you would need and often see in a primary care setting. Our mission is to advocate for nurse practitioners and the patients that we see. And so just getting that dialogue started about what our capabilities are as a nurse practitioner and how we can fill those gaps and heal the fracture that we have in healthcare right now.
Yes, and I would add that we are really not a substitute, but a collaborating partner. So often in our history, especially in Manitoba, we were seen as a substitute. So when they couldn't fill a role with a doctor, say in rural or remote, they would have a nurse practitioner. Well, that's great, but we come from a different perspective. We have our history, our nursing foundation, which allows us to be very holistic and partnering with our clients and the people that we work with, right? But also we have that medical knowledge that we go back to school to be able to integrate within and just sort of level up our abilities to be broader scope, broader sort of focus area to really be able to provide that relational care with clients to help them make the decisions for their own care. So it's really, we're collaborative in what we do. It's not a top-down kind of way that used to be for healthcare, where you go in, the doctor and say, this is what you need. Here's a prescription. It's a lot more. It's educating. And in advocacy, we also educate a lot. So we educate on, like Ashley was saying, what we do. Lots of people still don't understand what a nurse practitioner does and how do we fit in the system.
How are you similar? How are you different for those of our listeners who aren't really very familiar with what a nurse practitioner does?
There is a little bit of a kind of a crossover in terms of scope of practice when it comes to a primary care physician compared to a nurse practitioner. But I think often what happens is that we get this unconventional discussion, and often nurse practitioners or even nurses might be scared to make that comment, is that there is not a lot of there's not a huge difference between what a nurse practitioner or a family physician would do in a primary care setting. And so we're still seeing patients autonomously, so just independent. We are diagnosing those patients. We are treating those patients. We're managing those patients for whatever health condition they might present with at that time, or even more of a long-term primary care provider type of situation. So there's a lot of blurred lines when it comes to what is the difference between a family physician or a nurse practitioner. We can do the same work. Our scope of practice is quite significant and high, and so you don't see a lot of differences, especially in the areas that a lot of our NPs here in Manitoba are seeing. I would say that we do provide somewhat of a different care because we were trained differently, right? And so that holistic aspect that Cindy has been saying is that we look at the entire patient in terms of their socioeconomic, mental health, physical, and kind of collaborate all that information into one to try to formulate a plan and a management strategy for that patient that will be going forward. Not to say that physicians do not do the same thing, but again, I might have an unpopular view on the fact that our practices are different in the way that we practice, and that is an example of how that is different.
That's interesting. And I can imagine there's probably a lack of education around nurse practitioners and capabilities of nurse practitioners. You mentioned earlier there's our healthcare system, especially primary care, is broken. I'm curious to understand from your perspective, what role can nurse practitioners play in helping to aid that?
Access, huge access. There just needs to be more providers in the system, period. Be that a nurse practitioner, a physician assistant. You know, we differ from physician assistants that we're not tied to a physician, where physician's assistant has to work within that scope of that provider that they're attached to. So, but we just need more of us. And so we are a valuable addition to the system to open up access, especially given our backgrounds. We have this social kind of approach from nursing, right? To make sure that we take into consideration those other non-physical kind of aspects that really can help set a person up for success in their health journey. And so, you know, we're really good at working with vulnerable and underserved populations and areas. And when you have a nurse that's grown up and working in a community, say rurally, that now wants to go back and pursue her nurse practitioner or his nurse practitioner degree, there's no better person to put back into that community where they're already invested. They have their family there, they have their job there. They're not going to be circling out, right? Where we find a lot of, particularly in rural Manitoba, what we're seeing is this cycle of physicians where they bring them in. They might be international medical grads. They bring them in and then they cycle out once they're done their term there. Whereas if you are growing your own in the rural areas where we are really, really lacking practitioners, that's where you're going to get them to stay because they're already invested. They're invested with their family. That's where their home is, right? So that's a huge place where we can make a significant difference for access, but just the quality. Just not to say again that our physician colleagues don't do a good job. They're under a different system. They're in a fee-for-service system where it's the number of patients you see, how quickly you see them, get them in, get them out, because every patient is $1. Whereas nurse practitioners primarily are paid salary or an hourly rate. And so we have sometimes the luxury, not always, but sometimes the luxury of having a longer patient visit where you can dig deeper and just do that preventative healthcare. So bandage healthcare is what a lot of our system is doing right now. You come in with a symptom, we give you a drug, and out you go. Where nurse practitioners dig a little deeper. What is it that kind of, let's back up the train? Let's figure out what caused those sort of, circumstances to get that person where they're at. And it's a longer term relationship that we see them over and over and over again to get at those different contributors to make an improvement, so that then they are not just becoming well from their condition, but they're becoming healthier and more well in a long-term lifespan approach.
And that's an incoming trend. Preventative care, longevity, these clinics are popping up everywhere. So it's interesting that nurse practitioners, so I didn't realize the funding model was different for nurse practitioners. So it absolutely makes sense. So there are nurse practitioner clinics popping up everywhere. There was an article published in early July of this year. CBC News published it, and it highlighted a private pediatric clinic run by nurse practitioners. The clinic charges fees, but aims to bill OHIP instead. The situation raises important questions around funding for nurse practitioners, the services, their role in addressing healthcare gaps. How does this situation compare to the landscape for nurse practitioners across Canada?
Yeah, you have nurse practitioners that are like those, that young child that puts her hand up and doesn't get called on to play in the group, right? To be part of that big group of individuals, because it's just, again, it's, there are NPs that are willing and ready to help out, to get their feet wet, to get into the practice and help to heal this fractured healthcare system that we have. And a lot of those nurse practitioners already come with, years of experience in whatever specialty they have been in before. So when you speak to a nurse practitioner-led pediatric clinic, it makes sense to me because those individuals probably have been practicing in pediatrics for the longest time before they actually became nurse practitioners. So the problem, from what I can see from this standpoint, is how do they get paid? Because you can have a lot of nurse practitioners that are opening up clinics, primary care clinics, or specialty clinics that could heal some of this fracture. But the problem lies with how do they get paid? If they're not able to bill their health authority or their provincial health, then it relies on a different funding model. And sometimes what that looks like is developing or taking healthcare dollars and developing a model that is salary based, depending on patient panel sizes or hourly, like Cindy had mentioned. So the restraint from where I see it is, how do you pay nurse practitioners appropriately and to the point where they are able to provide open up access by open up these clinics, and nurse practitioner led clinics is just a perfect example of that.
Yeah, we really do have a situation where nurse practitioners are seeing where the gaps are, seeing where the opportunities are for a nurse practitioner led clinic to really bridge those gaps or fill those gaps. And particularly when it comes to different areas of specialties. So primary care is a specialty in and of itself. That family practice holistic care is a specialty. It never used to be seen that way, but even with our physician colleagues, it is seen as a specialty in and of itself. So it's no different than setting up a headache clinic or a women's clinic. And so if we have this, if nurses are great, as well as nurse practitioners, are great at seeing where the need is, and then identifying that and creating a solution. Where the problem is the system hasn't been able to keep up that quickly, right? They can't create the positions, they can't create the funding, and because there's the federal dollars and provincial dollars, and often the federal dollars for care for nurse practitioners go into the nursing pot. What happens is that all gets sort of filled into acute care typically, and there's nothing left over for the primary care nurse practitioners. What we really need in this federal system is that dollars are separated for nurse practitioners like they are for physicians. If you want us to be working in the role, similar to what our physician colleagues can provide, you need to adequately fund those programs and clinics. And the federal dollars need to drive that. They need to say these are earmarked for nurse practitioners, or put us towards where the physicians are. That kind of, don't lump us in just with nursing, because we will never see those dollars created to be earmarked. There needs to be some accountability that way. And you're going to see more and more private practices come up because we aren't excluded currently aren't part of the Canada Health Act. So we don't have those restrictions. It allows us opportunities to be able to meet the needs of the population. And that's what we're used to doing. We're not just clinicians, we're scholars, we're educators, we're researchers, we're advocates and really pioneers. That's what nurse practitioners have been in this country, as pioneers from the beginning.
If nurses are eventually paid the way physicians are paid, is there a concern that the appointments will go back to being rushed and et cetera, et cetera?
Well, fee-for-service care is not good for anybody. It's not, when you think of a primary care model of care, fee-for-service doesn't fit well into that. And that's very well established in the research across Canada. And so we need to look at it from a broader perspective, not just from, try to pigeonhole us into what already exists. It doesn't work well already. So why are we trying to recreate a bad remuneration model? But, there is a role for some fee-for-service kind of situations. If you have a nurse practitioner that's working in an urgent care clinic, that might be where that fee-for-service comes into play. But when you look at the holistic and time-intensive care that needs to happen for mental health, for chronic disease, for prevention care, it fits better under either a capitation or some other kind of blended model. So that's the situation we're at federally. Is it's not good for physicians, it's not good for physician assistants or nurse practitioners. It needs to be different on the whole, but not quick enough.
There's definitely an issue in finance when it comes to how that plays out in patient care. And that's obviously very foundational. Have you seen success with nurse practitioner clinics that are popping up that are paid for through fees?
100%. So patients that have the ability to afford care outside of the system are taking advantage of that. And there's advantages to those that can't afford that themselves, because it opens up a spot within the system. If you have somebody that's, just going and, waiting their turn, it slows down the whole system. So when those individuals that have the ability financially to be able to pay for their spot, yeah, they're getting preferential care, but it's not taking away from the other individual's care. It's actually speeding that up. So there is some advantages to that. Would it be nice if nobody had to do that? Yeah. But where we're seeing nurse practitioners in particular doing well are in those disadvantaged areas or the underserved areas for primary care, where they're setting up these clinics because nobody else seems to want to go there, or the region doesn't want to fund it. They don't see the need like the population. And sometimes there's actual funding from the municipality or other philanthropists that come in and say, we want this here, we're going to support you in this. And then also some of the specialty clinics. So migraine clinics, women's health clinics, mental health and addiction, where there's just not enough resources within the system. Nurse practitioners are saying, you know what, I've got the knowledge, the skill, the ability. I am going to partner with whoever to get this up and running so we can meet the need. And patients are willing to pay for it. They don't like to wait, especially when it comes to their kids. They're willing to pay extra because they want their kids to be taken care of. So that's that pediatric clinic. It doesn't surprise me at all.
I'm so curious to know how many clinics have popped up over the last 3 to 5 years, nurse practitioner led clinics.
I think that would be a really good sort of survey to find out.
Exactly.
We're finding, so in Manitoba, we're a unionized, so any nurse practitioner that's working in the system is typically unionized. So we have a good idea looking at the union, like who's attached to a union, how many nurse practitioners in the province have that type of role, right? So about 50% of nurse practitioners registered within the province are members of our union within the province. So that tells me about 50%. Now this is, just my guess, but about 50% would be in one way, shape, or form working for either contract or self-employment or sort of the telehealth contractors, or maybe working under a contract with, say, Indigenous communities. Right. So it's alternate funding. It's not funding that's coming from the federal government to the provincial government and then out that way. There might be some from rural or on some of the reserves that would be earmarked directly from the federal government. But it's not a huge amount for sure in Manitoba.
The role of nurse practitioners seems like a great solution to our healthcare problem, just with more access, allowing for more access for patients in need, reaching rural areas where there are no primary care physicians available. So I think this is very interesting. I'm curious to know what trends you see in primary care and how nurse practitioners are adapting to these changes.
Yeah, I think what you're seeing is that it's just this increase in scope of practice and the autonomy that's provided within these clinics. And so thinking about some of the health authority clinics that we have in Winnipeg, you have that kind of team-based approach that takes place, or you have access to a nurse practitioner. You either paneled part of a panel or roster of a nurse practitioner or a physician, and then you have the primary care nurses, and you have dietitians, and you have some counseling, mental health, and you have pharmacy. And so you see great outcomes with those types of approaches to healthcare. And I think nurse practitioners have really stepped up and started to realize that those essentials, that collaboration with different disciplines, works well for their patients. And so it's just that adaptability, being able to go into situations where we are there for the patients and we want to see them thrive in whatever manner that can take place for that patient. And so I just think that you just see a lot of adaptability among our nurse practitioner colleagues that allows for that.
You're touching on team-based care.
Yeah, and I think you're seeing some unique roles or ways of looking at where's primary care happening across Canada. So not only is it in these community health centers or primary care clinics, but you're seeing it in mobile health units. So like I was on a mobile clinic where we were literally on a bus and we would travel out to rural communities. We're seeing it through the telehealth services, those private companies, and even some of the ones that are supported through our government to be able to have that access for those that can't physically get in, so homebound patients, or just a quick, this is, they have pink eye or something that can be managed that doesn't necessarily have to be seen in person, right? But we're also seeing primary care in a different way. So thinking of our citizens that are living in personal care homes, that is primary care. They're living there. We are going to them to provide them holistic care. So we know there's a ton of research that nurse practitioners do well when they're leading the primary care for seniors in care. And then leading to see clinic teams that can go out into homes so that people can age in place. They don't have to, it extends the time that they can be living at home rather than having to move to a personal care home or a long-term care facility. We see school-based health clinics that meet not only the needs of the kids within the school, but also the teachers, the resource people, and then the community that surrounds that school. So it's another way of looking at where's primary care happening, because it's happening everywhere. It's not necessarily that traditional brick and mortar building that used to go to get your immunizations and see your doctor. It's happening out on the streets, and we have teams that are going out and meeting people that are without homes, right? So living within inner city, but also rurally, that we're going to them rather than them having to come to us. And that breaks down barriers in and of itself. When you have people that are willing to go into their home or where they're living, they don't have that barrier where they may have had some trauma or experiences that sort of don't lead to going into the traditional primary care clinic. It's meeting people where they're at, and that's beautiful, because that's really partnering with them rather than telling them again top down what you need.
That's so interesting. It's interesting that there are solutions out there. It just seems like a lack of education, perhaps a lack of access. I wanted to bring something up. In 2020, the CIHI released data on nurse practitioner scopes of practice across Canada and all its provinces and territories. Manitoba seems to be the one with the least restrictions. And so, curious from your perspective, how do Manitoba's policies support nurse practitioners in delivering a broader range of services without the financial barriers faced by other?
That document that was put out has since been updated by a policy consultant we have here in Manitoba, Dr. Elsie Duff. She's a scholar at the university and really did some hard work because it was our belief that we aren't as different as that report said. And in fact, we aren't. If you look across Canada with the updated scopes that are continually changing, policies changing, regulations are changing, they were actually not that dissimilar anymore. There's only just a couple of areas when it comes to mental health admission for hospital treatment. That's really where the sticky wicket is, and not so much the rest. We're pretty solid, but you're right, Manitoba led the way a lot. And so again, we pioneered with our government to say, why not? Why can't we have a broader scope? Because this is the benefit you're going to get from it. If you allow us to do these kinds of roles and this scope, this is the benefit you're going to get, which is really only going to enhance the access for our clients, the quality care that Manitobans really deserve, and allow those in politics to get reelected. Really.
Again, it comes down to funding and being able to have that ability to practice as such. And so, again, it comes down to education and educating our counterparts and our patients of what we can do and how we can provide great care with having this substantial scope of practice. And so I think that's, NPAM continues to do that and continues to advocate for that as well at the government level, that here's our scope of practice, now use us. We're ready and willing.
Yeah, and you know what, a really good example of that is ability to admit and discharge from hospital. That is across the board in Manitoba and many provinces that we can do that. But yet then it's so that legislative layer says, yes, we can do this. Then it has to come down to those regional health authorities to say, yes, we want you to admit and discharge within a certain hospital. And in Manitoba, that just hasn't been transferred. So when I worked in a rural community where the doctors left and I was left with a panel of 3,000 patients and a hospital that had nobody to run it, they suddenly said, guess what, Cindy, you can admit and discharge because we need you to do that, because it was during COVID, we had a full hospital, 18 beds full of COVID patients. And so, where there's a will, there's a way, but also it's continuing to remind those in leadership that we're here, we have the ability, you just need to give us the legal stand to be able to enact our full scope and be able to work to that full scope.
Right. Can you provide any examples or specific programs or collaborations that have really demonstrated a significant impact on patient satisfaction, access to care, and or better health outcomes?
Well, I think Cindy has a great example of just what you were speaking of, right? In rural Manitoba, in a hospital that became NP-led.
It did. And so that was, it was a new community. It was a new role for me. There was never a nurse practitioner in the community before. The two previous physicians were fee-for-service physicians, that one moved away and one retired. And so it left two clinics and this hospital that served both of these communities without any providers. And so they decided to hire a nurse practitioner and two internationally trained physicians. And so when I started, everybody wanted to be on the doctor's panel because they had no idea what a nurse practitioner was. And so, but within 6 months, I had a larger panel size than both the doctors. And that was just because of not knowing and then realizing the type of care that nurse practitioners provide. And so that was great. And then come COVID, the doctors left. It was unfortunate, but I get it. It was a situation. They weren't from here, and COVID hit, and that changed everybody's lives. And so they both left, and I was left with this large panel and a hospital. And so the choices were for the community to shut everything down and not have that access, or let's look outside what we traditionally would do, and let's challenge the system. And so through the collaborating with the medical director at the time, who was supportive of nurse practitioners, he wasn't sure how we were going to do it. And I said, well, why not? Let's just go and what's the worst that could happen, right? You fail and you try again. So let's try. So they tried hiring physicians, just didn't work. So we then switched it to a nurse practitioner-led model. So nurse practitioner-led inpatient hospital, 18 beds full during COVID with COVID patients. And urgent care, it was emergency care, but we switched it to an urgent care just because of limited resources. And 2 fully functioning clinics, family practice full clinics that serviced 3,000 patients. And so we hired an additional 3 nurse practitioners and myself, and we ran with it. We had support of our local community physicians that were within other partnering or within commuting distance communities. And so we could call on them if we had concerns or we needed to transfer a patient out. So, we know our scope of practice. We know what we're comfortable with and what we do not want to stay or needs, just what's in the best interest of the patient and the family, right? So it worked really, really well, but it is still difficult to hire into positions in rural. The nurse practitioners that continue there are all living in the community or surrounding community. They're the ones to try and get people to come to move out. It's really, really difficult. It's no different for nurse practitioners as it has been for the physicians, but it worked well. The community is very happy with the model that they have and wouldn't turn back at all.
Such a great example. Are nurse practitioners easier to hire than physicians?
Not easier to hire. We take less time to prepare. So nurse practitioners have our undergraduate degree. So it's a 4-year degree. We come out and we have to have 2 years, usually about 2 years of nursing full-time practice before we can go back to get our graduate level education. And that's anywhere from a 2 to a 5-year degree, depending on whether that's a full-time or part-time. So you just will get that fully functioning nurse practitioner faster than you will a physician. Right. Because they're 8 to 10 years to be able to have them out. Because remember, once they graduate as a physician, they don't go straight into family practice. That's a specialty of its own. So they have to do a residency now. It's almost a longer process for physicians to get into primary care family practice than it was in generations before us.
Right.
Canada is pioneering. We are known for just starting out and saying why not and go for it. And the private clinics are really pushing the envelope that way, right? So I think, do we have the evidence that we're making a financial difference, or it's more anecdotal than anything from that right now? But we're certainly increasing access because it's just way, way, way too slow waiting for the system to build that access. And where they're building the access is typically where they already have centers that are built, like they have. So it's just allowing the nurse practitioners to work with community from a grassroots perspective up allows that what the community really needs is what's being built. So it's culturally sensitive, it's socially sensitive, it's really working with what that community thinks they need, right? Not just from that top-down approach of you will do interdisciplinary care and these are the people we're going to put in there. It might not be what the community actually wants or needs, where the nurse practitioners that are setting up these clinics, and a few that I know, have done that groundwork to say, I'm going to work with the community. I'm going to do those stakeholder meetings. I'm going to get to know where the funding is from philanthropists or from municipalities that are willing to kick in some money, right? Because, it builds, if you have a community clinic, that's also going to attract people to want to move to that clinic and build houses or buy houses. So it's in their best interest as well. And that was one of the things that we used as something that was important in the community that I was in.
I really like what you said earlier, meeting patients where they're at. I think that's key to primary care in general. And it's interesting how the role of nurse practitioners really focuses on that.
Yeah, it's also
foundation.
It is. It's the meat and potatoes of our education and our foundation as a practicing registered nurse to nurse practitioner. We look at that preventative care and that holistic aspect of the patient, looking at all of their needs, not just what they came in for that day. And that is what makes us unique as nurse practitioners.
Thank you so much, Ashley and Cindy, for sharing your insights and experiences. For listeners, thank you for tuning into this episode of Prescription for Primary Care. Of course, if you have any questions or comments, feel free to reach out. Until next time, stay healthy and informed.